Dear viewers, welcome you all to our show OSA, that is Orthopedic Solution Academy. Hope you all are well during this overcoming situation of COVID-19. Dear viewers, today our topic is deformity around ankle, treated by Ilizarov. That is the magical Ilizarov. And the presenter is the one and only, the legendary Ilizarov surgeon of Bangladesh, Professor Mofakkarul Bari sir. I would like to request Professor Mofakkarul Bari sir to join with us. Good afternoon, sir.
Mhm.
Good afternoon, sir. Can you hear me, sir?
Yes, I can hear you. Can you see me? Again, good
Yes, sir.
afternoon to everyone. Thank you
Yes,
so
sir.
much. Okay.
Dear viewers, we have three learned academic experts from all around the world. One of them is Professor Novikov sir, highly academician from Kurgan, Russia. I would like to request Professor Novikov sir to join with us. Good afternoon, sir. Dear viewers, we have another enthusiastic Elizabeth surgeon from Patna, India. That is Dr. Shamsul Huda sir. I would like to request Dr. Shamsul Huda sir to join with us.
Good afternoon and welcome from India.
Good afternoon, sir. Dear viewers, now I would like to request Professor Omar Barabi sir from Kurdistan, Iraq to join with us. Professor Omar sir.
Yes, good afternoon. Thank you so much for your kind cooperation. Good afternoon.
Good afternoon, sir. Dear viewers, now I would like to request our honorable speaker, Professor Mofakkarul Bari sir, to start his presentation. Sir, would you please share your screen with us and start your presentation, sir, please.
Okay. Dear friends, my dear colleagues, and all the orthopedic surgeons, especially the Ilizarovians. Today, I'd like to share my experience with the deformity correction around the ankle. Although this is a very difficult situation when we can overcome a lot of cases by Ilizarov technique. See this, my institute in Kiev, Ukraine capital, left side. You can see two buildings. 2 years back, there was 100 years of this institute, which was established in 1841, more than 100 years. You can see here. So this is the institute where I've taken my MS course, and I have learned a lot of things from this institute. And now what is going on? And this is the right side, the Tashkent, where I did the PhD from Uzbekistan, Tashkent Central Institute of Traumatology and Orthopedics. This is the Kurgan, you know, the orthopedic capital. This is our institute, NITO, National Institute, now the 1,000-bedded Ortho and Trauma Hospital in Dhaka. These are my places. This is my center where I'm doing Ilizarov and other cases. And the, you know, this is the gentleman. Those who are related with all kinds of external fixators, you must know the gentleman. He is Professor Oganesian. Although he did a lot of cases by his technique, and he was working in the CITO, Central Institute of Traumatology and Orthopedics. And I had the opportunity to meet him in 2003 in Moscow CITO, and he was just teaching at that time with his apparatus. He was the rival of the Ilizarov, Volkov and Oganesian. Volkov was the director of the institute, and according to Professor Oganesian, injuries of ankle joint can be considered as chronic when 2 to 6 weeks passed since the injury, that is until primary union of the fragments by membranous regulated tissue with Ilizarov. Restoration of ankle joint anatomy is possible by at least 4 to 6 months post-injury. So this is Professor Oganesian, and he has the external fixator book, not full ring with half ring and 5/8 ring. He has his own device. So how ankle joint is formed, this is the basic things: articulation of the talus and tibia and fibula. when you are treating any kinds of ankle injury, sometimes you will find the deformities related with the ankle in the foot, in the hind foot, in the mid foot, and in the forefoot also. So this is the view. Just you can see, have a look. And what two joints form the ankle joint? Ankle joint is talocrural joint. It's complex hinge joint composed of two articulations. And what are the moments you will find in these here? Plantar flexion, dorsiflexion, inversion, and eversion. Deformity is a deviation from normal anatomy, and we all know this. And contracture, deformity of joint due to soft tissue. What is contracture? Limitation of movement in a definite direction is called contracture. Ankle deformity, when you think about that, you'll see the individuals with injuries or congenital conditions that are present at birth may have ankle deformities. Ankle fractures or other trauma can change the shape and function of the ankle. So these are the just simple, so that you can have a look how the foot, ankle, and other bones are related. And whenever you are talking about the ankle deformity, you can see here the varieties of deformities related to the ankle. Talipes cavus, Talipes equinus, Talipes equinovarus or equinus, Talipes valgus, Talipes equinovalgus, and calcaneovalgus, and these are the varieties of ankle deformities. And what are the types of ankle deformities? Common types of ankle deformities are varus ankle deformity, where the foot turns sideways toward the opposite foot. Valgus ankle is where the foot turns sideways away from the opposite foot. A talolisthesis is where the talus translates forward or backwards related to the axis of the leg. How are ankle disorders diagnosed? How you can put the diagnosis? To diagnose an ankle disorder, your doctor will evaluate your symptoms, examine your ankle, and ask about any recent injuries. To look for bone fractures or tendon tears, imaging tests will be needed. These tests include, as you know, all the time we go for X-ray and MRI, and of course, sometimes we had to go for computed tomography scan. And this is the understanding of any kind of deformity. When you're going to correct any kind of deformity, you should keep it in your mind before embarking the deformity correction. Please remember, there is a deformity, or is there bone is deformed? And where is the source of deformity? It may be congenital or acquired, and level of the deformity, and which plane of the deformity you have to correct, and what are the angulation or magnitude of the deformity, and where to do the osteotomy. And there are varieties of osteotomies, and what type of osteotomies you are going to do, whether you are correcting accurately or you are going for gradual correction, and which kind of fixation, either you are going for internal or external fixation. As we are the Ilizarovians, we love to do the external fixation and never operate on the wrong bones. So these are the understanding of deformity correction. And this is, deformity analysis. If you are okay, if I am okay, you are okay. That's a normal alignment. I am okay, you are bad. How to measure and define deformity. Intelligent games means deformity options for correction. You come on my couch and I'll treat your deformity. So now let us share some cases. See, this is a very interesting case. 14 years old boy, sequelae of post-traumatic left knee dislocation. Ankle equinus. As a result, what you see here, clawing of the toes and ulcer in the lateral border of the foot. He was treated elsewhere due to ankle injury. And he came to my place with this. You see? So related with this, with the ankle. Then what I have done the 2 blocks in the tibia, and this is the hinges, half ring, and multiple quires through the toes, and this is the full ring. And gradually I have distracted this one from equinus. This is already 90°, and you can see here the lateral border ulcer was gradually diminished. And this is the radiographic view with Ilizarov fixator. Now you can see here, dear friends, this is before, this is only after 3 months. Look at these. And this is the standing position of the patient, and clautos already diminished, and you can see the lateral border of the foot. Now, case 2. This is why I'm showing you the old case. This was neglected equinocabovirus. Look at these bony deformities, and look at the cavus, look at the equinus, and look at the short foot. And what we have done during treatment, see 2 blocks here with hamstring, with hinges, and gradual destruction. And after treatment, this is before, this is after treatment, after 4 months of treatment, 25 years old. We have not done any kind of bony, intervention. You see, sometimes you need to go for bony intervention, but here we did not done anything in the bone. And case number 3, you can see here, post-traumatic right ankle deformity with 4 centimeter LLD of a 27 years old man. You just look from the back side. This is from the front side. And this is the X-ray. You can see a deformity. If you draw a line through the talus, this is not in the normal alignment. So you need to go for osteotomy here. And we have done the osteotomy here. See, and gradual correction, opening wedge osteotomy. And then we have corrected the deformity. Look at this. This is front view, right side. This is the right side. Look at these. After 6 months of correction, how this is the 4 centimeter LLD with deformity. Now you can compare after 6 months of only a little bit restriction of the range of movement of the ankle. Otherwise, patient was feeling very well, patient is totally satisfied. So this is the case C, again related to the ankle, and of course the foot of laceral injury of the both foot and ankle, 6-year-old girl. Look at the X-ray here, and damage here, soft tissue. And then initially he was treated elsewhere, came to my place, and I put the one ring here, simple, and with olivers from this side and that side, and gradually the wound was healed. And as a result, after 5 months, you can see, if you compare the time of injury, and totally cured soft tissue and bony deformity. So this is another case. You can see here ankle valgus of 8 years old boy. Look at this X-ray. This is from front view, from back view. This is the valgus. And then what I have done, she had a deformity in the hand also. So I would like to show you only the ankle deformity, and then gradual correction, controlled coordinated stretching, which helped her to go for correction of the ankle. And this is the final view. You can see here, this is the before, this is after 5 months follow-up, AP and lateral view. A little bit change here, but the full valgus was corrected. And let us see the another case, open dislocation of the left ankle joint due to fall, 50 years old lady. See, these are the fresh cases, open, and then as soon as patient, you can see here, this is the malleolus and dislocated of the whole ankle joint. Then open injury, you can put the Ilizarov with 2 blocks in the proximal, in the distal tibia, and half in the calcaneum with hinges, and this is the half ring. Okay, and then gradually she was treated, and this is just after the trauma, before and just after dismounting of the apparatus, after 3 months follow-up. Full correction, and the healing process was fantastic. So this is the case. Again, you can see post-operative right ankle varus deformity of 43-year-old man. Look at this. He was treated elsewhere by fixation of the talus and the calcaneum. And at the same time, you see the joint space of the ankle joint is reduced. And she came to my place with severe ankle pain. And then what I have done the subtalar arthrodesis here, subtalar arthrodesis with the 2 blocks in the distal tibia and hovering here. And you can see here with hinges and fix the subtalar joint. And this is you can see here after before treatment, and this is the subtalar joint arthrodesis, and after 4 months follow-up of the painful subtalar joint. And this is a case of left, the left ankle post-traumatic ankle deformity of a 13 years old boy. 13 years, remember, this is 13 years old boy. If you look at this, here you can see a bony bar here, considering the age of the patient, and he has the 5 centimeter LLD. What I have done, look at these friends. Look at these 5 centimeter LLD with the deformity with shortening, because the growth plate is injured here. As a result, you are getting 5 centimeter LLD. And what I have done the osteotomy in the medial side, and gradual controlled coordinate stretching by putting the 3 rings here. Why? Because it was 5 centimeter LLD going for lengthening, and here the hinge at the line of the true apex of the deformity, the corona. And then finally, after 6 months, I've corrected. I followed up this patient. This is after 9 months. And then you can see this is after 3 years follow-up of 13 years old boy. No change. So no change. 13 years, growth plate is almost going to be closed. Now 5 cm LLD from front view, back view, and look at this here. The surface of the ankle and the bony condition of the ankle. And this is after 3 years follow-up from this situation to that situation. This is without touching anything, because the patient is running 13 years. Sometimes you need to go for 2 times surgery. But here you can see follow-up. Now he's running 16 years, no problem. Jumping, playing, he's doing everything. So this is the case. Now you can see the bimalleolar left side, 17 years old girl. This bimalleolar fracture. These are the cases that you can go for plating or screw fixation. Whenever Ilizarov in your hand, look at this. Very simply, you can correct these kind of deformities, ankle injuries by putting the 1 ring here, and then you just put olive oil through these with half ring here in the calcaneum and fix the syndesmosis here. And this is, she had a bimalleolar fracture. This is olive with 1 post, 4-hole post, 3-hole post, and you can fix this way. This is the AP view, and this is the lateral view. You can see here how you have reduced both the medial malleolus and the lateral malleolus. This is just after this pound in the apparatus. Look at this. You don't need to open anything. And the design of or geometry of the ankle is okay. You don't see any problem here. And another case you can see here, pilon fracture of a 58 years old man. You can see here pilon fracture. Look at this combination. Look at the fibula. Look at the tibial lower end, and at the same time the ankle and age of the patient. And then what we have done, if you look at this configuration, you put 1 ring here, 1 ring here, and just try to pull the, look at the AP view. What we have done, you put the olive oil here, and then you reduced all the multiple lot of fragments here. You don't need to go for open up here. And then what happened, you can see after the removal of the apparatus, look at this here. This is the lateral view, this is the lateral view, and this is the final follow-up after the treatment by Ilizarov apparatus. And now I'd like to share one very interesting case, which is not only the ankle subluxation in combination with fast metatarsophalangeal joint deformity of 90 degree. This is not only with the ankle, although my topic is going for today is ankle correction. Sometimes you'll see a lot of cases which are related not only with the ankle, with the other problems in the foot and the toes. So this is the 7 centimeter LLD of the left leg with bad scar and hard skin discoloration in dorsum of the great toe. Dear friends, you can see here the X-ray. This is the picture. This is the picture. Sorry, this is the picture of the patient. Just look at the great toe, and this is the great toe. And then look at this hard and discolored skin over the dorsum of the great toe with ankle problem. This is the X-ray, radiographic view of the equinus and 90 degree of the tarso-metatarsal joint. And then what we have done, he was my fellow at that time from Jordan, Al-Sharif. He's doing very, very good in Amman now. He was after doing surgery, the OT. Look at this. Left foot after 21 days of application of the mini Ilizarov here. Here you have done the osteotomy for lengthening purpose and gradual controlled coordinate stretching, which helped to correct the first metatarsophalangeal joints. This is the lengthening part. Lengthening part is going on after 2 months follow-up. And this is, you see, the deformity correction of the ankle, clinical photo of the left ankle with almost corrected first metatarsophalangeal joint. And now, after dismounting the apparatus, you can see the full length of 5 centimeter LLD and correction of the first metatarsophalangeal joint. Now, you can see the X-ray before treatment. Look at the ankle. This is the ankle. Look at the ankle. Look at the first metatarsophalangeal joint. Now you can see the after treatment. Here is the before. Where is the ankle left side? Here is the ankle left side. Now in the same level after correction of the first metatarsophalangeal joint. So now you can see ankle equinus, 90 degree deformity correction, and 7 centimeter LLD. Now you can see here after correction of the whole limb of first metatarsophalangeal joint. And then this is the final. And this is Ilizarov fixated. I always love to show this one and tell about that biological principles of gradual destruction has given us a lot of things by which you can go for limb deformities. These are the important things that we can go for LLD, bony and joint deformities, soft tissue contractures, bone loss, delayed and non-unions. You can cover the infection. Whenever you need, you can go for transverse destruction also. And where the circulation diminished, you can go for correction by this Ilizarov technique, that is the ischemic limbs. And the case that I've shown you, this was published in American Med-Crib Journal. This is the case. This was published in 2021, last year, the case. So, dear friends, these are the cases that I've shown you a little bit experience. It is not all the time to show you all these things. What I have shown you, this is of course the evidence This is the science or the basis of science. And of course, every surgery depends on the surgical skill of the surgeon. And what I love to see, I love to show you this. What I have done, this is the biology and mechanical stability of the Ilizarov fixator. And in our country, we are doing a lot of cases which is biologically cost effective. Thank you so much for your kind attention. Thank you.
Thank you very much, sir, for your magnificent presentation. Now, I'd like to request Professor Novikov, sir, to say something regarding the presentation. Professor Novikov, sir, can you hear me, sir? I think there is a network problem there. Now, I would like to request Professor Omar, sir, to say something regarding the presentation.
Okay, thank you so much. Congratulations for your nice job. I would like to ask him, what about difficulties regarding patient selection and patient satisfaction? Because it is different from one country to another one. In my country, we have a lot of problems because so many doctors, they have different ideas. Even they are encouraging the patient not to continue on the treatment. So I want to ask him about his experience in Bangladesh, about patient selection and patient satisfaction. Thank you so much.
Thank you. Very good question. Before
Yes.
Doing any surgery by Ilizarov, you must counsel the patient. You must open your heart. You must tell the patient that during the treatment, your time this is a difficult case. It will take long time, and sometimes you'll feel pain. You should have to accept that one. These are all temporary. When your course of time treatment, 2 months, 3 months, or 4 or 5, 6 months, you should have to bear the pains, and you have to bear this apparatus just like your wife. I tell Ilizarov apparatus is like your wife. Sometimes you should have to convince your patient that you can bear this with a little difficulty. And outcome, if you follow the instruction of doctor, my instruction, then outcome will be good. So in this way, I always try to counsel my patient. Sometimes you will not 100%, you will not get the good results. Even then, you should have to proceed with this technique. Some cases I have shown you, the difficult cases with deformities, Ilizarov still is the best option with the deformity cases. In trauma, you have other options. You can go for screw fixation, plating. But in case of deformities, lengthening, shortening, any kinds of deformity, Ilizarov gives a fantastic result. That's why we must counsel the patient before doing any surgery by Ilizarov technique. Thank you so much.
Thank you.
Thank you very much. Now, I would like to request Dr. Shamsul Huda sir to ask any questions regarding the presentation to Professor Mafakarul Bari sir.
Thank you,
Dr. Shamsul Huda sir, please.
Thank you. Thanks a lot. Thanks, Bari sir, for a wonderful presentation, including so many variety of cases in which we can put on Ilizarov, any deformity, any injury, any infection, where a normal orthopedic surgeon is not able to treat, he's not knowing. So one must have a good knowledge of Ilizarov, because being a normal orthopedic surgeon, somebody doesn't know if this thing cannot be treated. So if you have a good knowledge and good training of Ilizarov, anything is not untreatable. Any deformity is not untreatable. We can correct anything beautifully. We can salvage all the limbs which can be amputated if the vascularity is there. I have one question, sir. In complex ankle and foot deformities, so do we go to calculate the different angles of the foot and ankle before the corrections, to do stepwise and exact correction whether the deformity is in talus or calcaneum or in the ankle or subtalar joint of foot, sir? What is the protocol, sir?
Listen, if you think about the ankle deformity in your ankle, you must go for ankle deformity correction fast. And if you have deformities in the midfoot or forefoot or in the hindfoot or in the metatarsal, and you can simultaneously correct all these deformities by Ilizarov. This is the beauty of Ilizarov. beauty of Ilizarov. So sequentially, you should correct the ankle fast. If your deformity is the ankle and in the metatarsal or the forefoot, you go for correction of the ankle fast. And gradually you can proceed midfoot, front foot, and the tarsal or the metatarsal or the phalanges. These are the ways. And one thing is that you know, all the time I love to tell this one, the Ilizarov law of tension and stress. Keep it in your mind. Lots of the orthopedic surgeons, they don't know what is law of tension and stress. Slow and steady traction on a living tissue creates a stress which is metabolically activated in biosynthetic and proliferative pathways. Biosynthetic and proliferative pathways depending upon the vascularity and the functional use. This is the law of tension and stress. So if you have a vascularity a little bit, you can increase the vascularity, and at the same time, you advise your patient to go for exercises, doing the exercise with the Ilizarov apparatus. And as a result, you will get a very good outcome of the Ilizarov apparatus. The principle, before Ilizarov, lot of external fixation were discovered, but the biological parameters were given by the Professor Ilizarov. And still, after his death, still the biological parameters is going on. There are lots of external fixators, SUB, you know, then hexapod, everything. Everybody is following the principles of Ilizarov. And that is the main thing. Thank you so much. Probably I have answered your question.
Yes, sir. Thanks you. Thanks a lot, sir.
Thank you very much, sir. Professor Navigam, sir, can you hear me, sir?
Yes, of course, but sorry, I haven't any information about Barry. Only a few seconds ago, Andrei helped me, and just now, next time, I will with you.
Okay.
Thank you, sir.
Okay.
Thank you very much, sir. Sir, I have a question, sir.
Computers. Pardon?
Sir, I have a question, sir. In case of arthrodesis, is there any procedure of denuding of cartilage there?
Yes. I have shown one case, subtalar joint arthrodesis. You just go with Ilizarov, you just denote the lower end of the tibia. If you want to tibiopatellar arthrodesis, you denote the cartilage and then fix with Ilizarov. There are lots of methods. Even then, by putting the rods through the calcaneum, you could put arthrodesis. With Ilizarov, you will get a very fantastic result. I'm telling you, in case of diabetic patients, we are getting a lot of cases. You need deformity, Charcot ankle joint with diabetic patient. Here we are doing arthrodesis, but in course of time, we are getting fibrous union. In diabetic patient, you don't get all the time the bony union. You will get the fibrous union. Why? Because bone quality is not good. It will unite, and in course of time, you'll see, you will get arthrodesis, but this is called not bony arthrodesis, not all the time. This is not bony ankylosis, the fibrous ankylosis. And with Ilizarov fixator, you can make arthrodesis. You can do arthrodesis in the ankle joint very easily. Thank you.
I have one question, Dr. Barry, for you.
Please, sir. Please, sir.
Dr. Barry, for young doctor, your recommendation, when doctor can start touch this problem, deformity around the ankle? Because today I have surgery after hematogenic deformity of the humerus, and young doctor asked, can I make it home? He come from another region, and never before this doctor never used external fixator, only plate and nail to the humerus. And my recommendation was, please not touch humerus before femur and before enough experience on the tibia. Your recommendation, like professor, like expert, when young doctor, after how many years of experience job with external fixator, when this doctor can touch this patient?
Oh, a very difficult question. You answer me. You answer me. You
What
answer
your-
me. I'm
what your
waiting
opinion?
for the answer.
And
Okay.
I think when young doctor start touch tibia, then femur,
Right.
then humerus,
That's
then
why.
forearm, then foot.
This is correct. I always tell my junior colleagues to gather experience by doing lot of cases in the tibia. Okay? Lot of cases in the tibia. Tibia is a so fantastic bone from any directions. You can put any kinds of wear. Whenever you are experienced Ilizarov surgeon, then you go for humerus. Up. Then you go for femur. Then you go for radius and Allah. This is the sequential. When you gathered a good experience, you are confident that you can do the pass the voice confidently. You know the safe corridors, safe zones. Then you can do whatever you like. That we are also doing at that. Still then, when you are doing operations, you must be cautious for all the time. Sometimes experienced doctor, very good experience, make mistake. Because mistakes can happen at any time in your life. So you will get mistakes when you'll do lot of cases, you'll get lot of mistakes also. And from that mistakes, you can correct yourself. And I learn always from my mistakes. And I learn from the junior colleagues. I learn from the senior colleagues. So this is the experience. Whenever you want to be a very good Ilizarov surgeon, you go for tibia first, then humerus, then radius ulnar, then femur, whatever you like. Thank you so much.
You're absolutely right, because all our mistakes, this is our teacher.
Yes.
Without teacher, we cannot get experience and knowledge.
Yes.
Yes, sir. Thank you very much, sir, for a nice discussion. And dear viewers, this is the end of our presentation today. And now I would like to thank Rajtv for helping us to arrange this type of academic program, and definitely Renata Pharmaceuticals Bangladesh Limited for sponsoring our program. I would like to thank our honorable speaker, Professor Mafakhrul Bari sir, and our academic experts from all around the world for being with us. I'm Dr. Mohammed Tanvir saying bye-bye today, but hope we will connect you with another magical Ilizarov topic in the coming Friday. Till then, I would like to say bye-bye.